Hello, welcome to another Renew Education case study. This is just a good little case that you'll typically see, and I'm just going to go through it fairly quickly, but we're going to go through it with the mindset of what the treatment assessment can do. The treatment assessment can add to that patient's chart really the important information that can go to other doctors. They can kind of evaluate your ideas or thoughts about what you've determined or at least looked at through the lens of a CT or through the lens of full arch rehabilitation kind of mindset. This patient has most all their teeth, but has experiences with implants, and so therefore comes to the office. I always tell patients we don't just do implants, but we look at the entire mouth for signs of problems and will those problems proceed, et cetera, based on how the whole mouth functions. So this is looking at the case. Is this something we do tooth by tooth dentistry, or do we do any sort of intervention kind of things to make sure that we maintain this patient in a situation where it's more like tooth by tooth. He does have a little bit of periodontal disease here, but so those things are always encouraged to just get the cleanings done, maybe see the dentist, hygienist 3 times a year or something, or 4 times a year is usually what we kind of go in between when somebody starts to have periodontal issues. We try to track them for 2 years. This would be one of those cases. But this patient has experience with implants and then loses a second molar due to decay around a root canal treated tooth. So here is how it's handled. So when we go through the treatment assessment is what I'm going to do. So in the future, when you look at a case like this, when he starts losing other teeth, you have an assessment of where he was, just like you have an assessment or at least a starting point with x-rays, and you can see a change. Not that many of these things change in the treatment assessment, but if it changes to a new doctor, the assessment should be very, very similar from doctor to doctor. And I think all doctors appreciate that there is somebody else's opinion there to counter or concur with. So let's take a look at this case now. Okay, so if we come here, let's look at that second molar area. I don't treat these, except in this case, we would just do an extraction. So I don't believe that this tooth, this is a, 65 plus year old male, and I don't think that this is really going to come down. He has this primary chewing area, and my questions to him were, does this bug you beside it being a missing tooth? Are you chewing on this side? Because he has second molars here. And he goes, no. And I go, well, do you chew a little bit more on this side? He goes, yeah, okay, sure, I guess so. So he doesn't have a sense that he has lost much here. And that's why I don't recommend second molars. The patient isn't missing it. It's when he's missing part of the primary area. So when the patient is missing part of that primary chewing area here, then it really matters, or here. But in that secondary position, I'm not concerned about exfoliation of those second molars here on the upper at all, especially somebody is 65. Sure, it's a lame duck. It doesn't do anything. If anything, down the road, if it does exfoliate, well, just take it out. I would rather not have a food trap back here between the first and second molar when that doesn't do anything in the first place. If you have to restore this, meaning the patient, at this stage for me, I don't even, if the patient begs me, I just tell them they can go, and I'm sure they'll find a dentist to actually treat them for that second molar, but otherwise I'm pretty much a stickler for not doing it. The other reason besides function is that it's usually more problematic to be restoring your crowns back here, especially in this case where the arch form is going up right away. That means the tissue is really coming down. So it's not putting the implant in. This patient, I believe, has plenty of bone. Let's just look at that. So it's not the bone problem here. It's more about the prosthetic, putting the crown on. I typically don't end up with a full-size second molar crown when I do these in the past, but I have had probably a good share of them, even where I thought everything would go fine, doesn't go fine. One of the problems I had with one person was that when I did, she was missing, it was just like this, but she was missing it for a long, long time. And what happens is that the tissue in the cheek or the tongue collapse into that space. So then all of a sudden I put a crown there. She is biting her cheek and biting her tongue, biting her cheek, biting her tongue. 6 months later, she just says, take this crown out. It's not going to happen. It doesn't work for me. So I'm done. I'm done with second molar restorations. So here's why the patient comes in. Not only here, but now is concerned about this side here. So let's look at that anterior one a little closer. And we're going to go right down that route. And here's the tricky part. What do you advise the patient to do here? They do have a little bit more tooth structure. Do you do a root canal? Do you do some big post and buildup, a core? Do you do an extraction and graft? Do you just try to wing it because doesn't have any endo here? And he's got some tooth structure here, and he's got a little bit of perio, so you can now bring that margin down a little bit. You might impinge on the biological width, and that would end up driving the bone down a little bit more. So this is a little bit of a challenge. It's not going to be super top heavy. I've seen worse. But because he's missing a lot of that facial area, and I see a lot of kind of evenness, I know he's biting a lot on the front here and grinding. And that plane of occlusion here, when you look at how flat the other doctors over the years have kind of flattened everything out for him to kind of get him to deal with all the excursions he has, I would imagine he's going to also be plummeting this top edge quite hard with the lower teeth here. So I'm a bit guarded on trying to do heroics with where he's standing now. So I wouldn't go for that. I also would not be going for weakening the tooth with an implant, a root canal either. That's one of those things that patients come to me for, is that they get charged for the root canal, the buildup post, all this stuff. And then 2 years later, it cracks away, and the patient's really pretty upset at spending a couple $1,000 to $3,000 on restoring one tooth when they see that they could have taken it out, grafted the site, and put the implant in for a very similar cost in that $3,000 range. So looking at this now, and this is what we ended up doing, was grafting the site. So now when we graft the site, we're looking at maintaining the bone height, which is about here. So if we just do our little check and balance here, now we're looking at bone height fairly high up, right? Because we're kind of now constricted to the bone height here. But, he can get a decent size implant in there. He's got, let's go back to this viewpoint here. He's got a good length. Let's look at that length. So if we have the socket graft healed, you can go up. He's got 17 millimeters. So if you put even a 13 millimeter implant in here, you can get away with that. Now, this tooth begs you to do an immediate placement. If you are experienced with immediate placements, this is a slam dunk case. If you don't know immediate placements, how they're going to end up, or keeping that facial plate there, don't do it. You do have a cosmetic problem in a lateral or any of the anteriors, especially the upper. And even if they're not cosmetically minded and they're very easygoing patients, I guarantee if there's a cosmetic problem with the defect in this gum tissue going up and metal or your implant even showing up, it's even worse. And that tooth looks really long, the patient is not going to appreciate it. They're not going to like it at all. They're going to hold their lip up and show you over and over again. So if the patient is great, realistic, I ask them, do you feel comfortable waiting a few extra months to allow this some healing time to get a more predictable outcome, or an outcome that we don't risk that there's going to be this future part of the implant exposure? Because every once in a while I'll do something like this. I will think it's a pretty good slam dunk. You get a lot of stability from the existing bone. You know you're going to get osseointegration, and then you get an infection around it. And then that causes that facial plate to melt away, which then causes the tissue to melt to the implant, which longer term has a bigger problem. So what I like about this case, though, too, is that you've got a really nice, you have just a basic class 1 situation. You're not dealing with a big flared overjet, overbite, or anything like that. So this is a good case to do if you want to learn about maintaining the gum line here. He already has recession around these teeth in the front. So you don't have to worry too much about talking about tooth elongation. You know, you take some pictures and explain that your crown is going to look as long as where these roots are exposed. He's totally fine with that. He's used to a lot of dentistry. He's used to successful implants, on and on and on. He's going to need implants in the future. So I really like this case, just looking at it from a perspective of straightforward, and you're going to be successful, and that there's a future here that you can stand behind now that you've documented the treatment assessment. So that's it for this one, and please give us a like on the Facebook channel, subscribe to us on YouTube, and check us out on some of our live broadcasts on YouTube, Facebook, Mixer, and Twitch. And we appreciate it. Take care. We'll see you soon.